Very cool. All right. So let me do a little bit of an intro about myself. We'll start the presentation, and um, do I have you guys for about an hour, something like that? Okay. Where are you guys based out of?
We have a bunch of pre-meds from across the country, so it
Okay.
depends.
All right. Well, good deal. Well, hello there. My name is Gil Salazar. I'm an emergency physician in Dallas, Texas. I'm an associate professor of emergency medicine at UT Southwestern Medical Center. It's my 11th year as faculty. So what that means is I'm a practicing clinician, but I have significant educational responsibilities on a day-to-day basis, some of which we'll discuss today during my talk. And I serve as medical director for my organization's EMS section. So everything pre-hospital, ambulance services, law enforcement falls under me. And very recently, I became medical director of the virtual clinical observation program at UT Southwestern Medical Center. So some of you might have heard about it, and I'll talk a little bit about that toward the end if that's okay with you. Before we get started, a couple of ground rules for me. This is not a one-way street. I want your questions. I want you guys engaged. There's going to be some engagement tools within the presentation, so make sure that you're kind of on it. You'll need a cell phone or your tablet or your computer. It doesn't really matter, but I do want you kind of engaging with the presentation when the time comes along. Um, and as if you have any questions specifically, you can put them in the chat, and I'll call you. And Abby, are you kind of my hostess for this one?
Yeah, you can just feel free to look at the chat whenever. It's completely up to you.
Sounds good. If for some reason you see something in the chat, Abby, that I'm not, for some reason I don't see it or I'm not addressing, just raise your hand and we'll go from there. Okay. I'm gonna start sharing my screen then, and we'll get rocking and rolling. Okay, give me a thumbs up, Abby, if you can see my presentation. Awesome. Well, guys, it's very nice to be here. When y'all asked me to come and say a few words and get to meet you, I wanted to give you guys a little something with a little bit of substance, with something you can take a little something to take from to further your careers, something that's engaging, something that you might not see every day. So what better way of capturing the spirit of this pandemic and the reason why we're doing all of this virtually? Okay, so give you a little bit of an insight about my life as an emergency physician, working in the front lines against COVID-19. And one of the reasons I really like this presentation is because it is my way of honoring you, the students, for doing your part in battling this pandemic. You all contribute by being home, by taking care of business with your family, by learning virtually, by adapting. Okay. So I have my duty and I put my life on the line for the general public and for my patients. So that's how I contribute, and you're contributing by being here today. So this is as much a gift from me to you more than anything else, and a chance to teach you a few things about emergency medicine. Okay. The first lesson of the day, and I really like lessons, okay, is that medicine is a calling of service. I took this picture several months ago when a dear friend of mine who doesn't live too far from me called me in the middle of an afternoon on a Sunday, telling me that he was having difficulty breathing. Okay. He was wondering if he should call an ambulance or he should call his doctor. And one of the first things that I want you guys to remember is that being a clinician, being a healthcare professional, like a physician or a PA or a nurse, it's all about service. What is the right thing to do? What if it was your mom or your dad calling you with this and you had the skill set and the knowledge to help them? What's the right thing to do? Well, I always go back to my training, and what I'm telling you now is that if you're interested in a career of service and a career of sacrifice, the right thing to do was to leave whatever I was doing on a Sunday afternoon, hanging out, pick up my work bag, and go help my friend. Okay. Was it a sacrifice? Absolutely. Was I satisfied with helping my friend when he was in most need? Yes. And I want you to take that perspective, that commitment to service going forward in your careers. If you learn nothing else from me today, remember that medicine, the skill set that you acquire is so that you can apply it toward the service of others. Making a good diagnosis, that's great. Getting to learn about medicine and cool tools, that's phenomenal. But why we're really doing medicine, kids, is so that we can be of service to somebody in need when they most need it. Okay. I'll tell you about my career path. I was born in Guatemala. If you haven't had a chance to take a look at the recording of my virtual shadowing video from September, I went through my life as an immigrant. We came to the United States when I was 10 or 11. Yeah. And I started my schooling right away. I didn't know a lot of English, but as a kid, you pick it up really, really fast. I was really blessed to have the opportunity to attend one of the premier high schools, private high schools here in Dallas, and it wasn't because my family was rich. As a matter of fact, we were really poor. We lived in a two-bedroom apartment, and there were six kids, two adults, and a nanny that was about 25 years old that lived with us. And as a kid, you never realize that you're poor. Life is what it is. But now, in retrospect, we were really poor. Okay, because of making good grades and because of the generosity of a lot of individuals, I was able to attend Jesuit College Prep, where I did my work. I was able to excel and I got a scholarship to attend Vanderbilt University, where I got my bachelor's in neuroscience. I decided to really heed a calling in medicine, a calling that I've had since I was a child. But it wasn't quite clear cut to me during my undergraduate years, during my pre-med years. But I took what's called a gap year, and I don't like to call it a gap year anymore. It feels like there's a gap in my life or something, and it's really not. I call it a kind of an enrichment year where I went to work, pay bills, grew up a little bit, matured, and that's when I really cemented my decision to go to medical school. I went to medical school at UT Houston, which is now called McGovern Medical School. And I went ahead and then did my residency in emergency medicine at Louisiana State University, right around Hurricane Katrina days. Okay, so that tells you how old I am. Yes, I'm pretty old. I then went to do my fellowship in emergency medical services. So everything that deals with ambulance service, law enforcement, etc., that falls under the umbrella of EMS. So I did my fellowship for 2 years, and then I stayed on at UT Southwestern, and I've been there ever since. Okay, so it's been a phenomenal career so far with a lot of turns, and just like I like running marathons, life is indeed a marathon for me, and I'm still running that race. So let's move on to a little bit of the actual talk today. So I want to get your engagement first and foremost, and I want to see how good is your understanding of what is happening on the front lines of COVID-19. And you can respond there on the poll, do it on the website. You'll be able to do it on your phone as well, but there's no wrong answer. I just want to be able to tailor my talk a little bit for you. And there is no wrong answer. I think that for you to gain the most amount out of this talk, I want to see what you guys can do. So I see a 4.5 right there. Thank you, Christian. All right, excellent. So let's see if we can start populating. You got a 4 right there. Naomi, thank you for your answer. And I've been to some talks where I do something similar to this, and you guys are all over the place, which is good. Okay, you're gonna be amazed today at some of the things that we're gonna talk about, because some of you who may think you're a 5, you may be a little bit closer to 4, and some of you who may be like a 2, you might be at a 4. All right. So now that we're getting some answers here, most of you guys are around 3, 4, or 5. That's excellent. That really helps me along. Keep this nice and engaged. So let's talk about what the front lines entails. The very first encounter when we started hearing of all these rumors of this kind of novel SARS CoV-2 virus coming out of China, all we really knew is that, well, we have no immunity to it. We know it's pretty contagious. We know that there's a possibility that we may wind up seeing it here in the United States. And the first things that started popping up in my mind is like, well, we have trained a lifetime for this. This is what schooling does. This is what sacrifice has prepared us for. On February 28th in 2020, I saw my very first patient whom I suspected may have COVID-19. It was that early in the United States. It was a gentleman traveling from Japan who had been in an airport in Japan and developed some very mild symptoms on his way to Dallas. Had a bit of a sore throat, etc. I won't lie to you, kind of a little bit of the nervousness, a little bit of the jitters gonna hit you because now you're dealing with something you've never seen before. Okay. But we talk about training a lifetime and putting the time and the effort into it. We go back to our basics. And so my resident Ty Stannard and I put on our PPE and we went to see the patient. Okay. Um, those were the days where we're not even testing people for COVID-19. We were just deciding, do these patients need to stay in the hospital or do we need to send them to the county health or what? All right. So we essentially had very little information to go on. I never knew what happened to that patient, but I can tell you that 2 weeks after that, that's when I saw for the first time my very first patient with proven COVID-19 in the flesh. And that's when the fun really began. Okay. So what's it like working on the front lines? Ladies and gents, you may be doing some scribing. You may be doing a little bit of work at the hospital level. You may have seen some shows or been to other talks. But my life in the hospital, my responsibilities from day to day is to provide emergency care no matter what the situation is. No matter what, we never turn anybody away. And it could be a motor vehicle collision, it may be a traumatic injury, maybe a myocardial infarction or a heart attack or stroke. And in the midst of providing my regular emergency care to patients, I have to be looking out because pretty much every patient that I see these days has COVID-19. Okay. So here is me putting on my PPE, and I want to point out a couple of things. Okay. First and foremost, I am wearing my N95 mask. I have a surgical mask on top of that, and I have my face shield with an extra mask on top. Why do I do that? Because I am not going to sit here and buy any of the baloney that's unfortunately a lot of the poor rhetoric and political rhetoric that got thrown around that masks don't work. Okay. I am here to tell you that masks do work. Otherwise, I wouldn't be putting them on when I'm seeing patients with COVID-19. If any of your family members or friends wants to have a frank discussion about masks, they're more than welcome to come with me. I would be delighted to take you into a patient room and let's see how you do without a mask. If you have the guts to do it, my kudos to you. You're going to catch COVID-19, but that's on you. All right. Additionally, I'm wearing my impermeable disposable plastic gown because we know secretions are one of the most significant ways of acquiring COVID-19. And I'm wearing my double layer gloves right there. One inner glove so that I can safely take off the outer layer. And just in case one of my outer gloves rips apart, then I have a backup. Okay. And you see my surgical cap. We know that COVID-19 is aerosolized. And so I don't want it in my hair at the end of the day. Yes, I will come take a shower, but I can feel a lot better if I actually have my surgical cap in place. Okay. And then if in the middle of things, I happen to get soiled with secretions, well, we have wonderful wash stations. I want you to notice something right quick. We have those signs that are sitting right there to my right, to your left. Okay. And when I see that on a patient's room, I know that when they came into the hospital, they have signs and symptoms of COVID-19. So if I see that sign on a door, I am going to put on full PPE when I enter the room. Okay. I got a question here from Deepthi. If okay to answer, could you please let me know, how does loss of smell and taste result from COVID-19 going to affect one's medical school life? It can be a short lasting loss of taste and smell. Deepthi, thank you for your question. It deals with basically what we call a kind of a viral neuropathy. It attacks your olfactory nerves. It should be self-resolving, though sometimes it can last for a couple of weeks. I've seen it last a couple of months. Sometimes it should not significantly affect your medical training. Okay. All right, let's have a little bit of fun with diagnostics. Okay, so I'm gonna just walk you through the case. These are real life cases, and I don't want you sharing these with anybody else because these are private. These are real patients with real families. On one fine evening in the emergency department, I was asked to see a 71-year-old gentleman, Spanish speaking, with a history of diabetes. His family brought him in because they noted that he was having some difficulty with his words, getting words out. Okay. He was kind of confused to the family. That was really out of the ordinary. They checked his blood sugar and it was normal. They thought something was off, so they brought him to the emergency department. You can see his vital signs right there. His blood pressure, he is hypertensive, he's got a normal heart rate. His temperature is normal, respiratory rate is also normal, and his oxygen saturation, which is the SpO2 pulsimetry, is normal at 97%. I performed a neurological exam, which was normal, but something was off about the gentleman. Part of being a good clinician is asking the right questions. One of the main questions that I asked the patient is, do you have any exposures to anybody with COVID-19? Well, unfortunately, the answer was yes. They were living with a son who had been diagnosed positive the week before this started. Okay. So, all right, team, I gave you a little bit of information. And what is your diagnosis with this patient? Remember, we're learning here, but it just goes to show you that in order to do the kind of work that we do as physicians, as physician assistants, as nurses, you need a lot of training, and you're paying your dues right now. All right. So is it low blood sugar, hypoglycemia? Are we dealing with a stroke? Are we dealing with a psychiatric emergency here since the patient was confused? Or are we dealing with the organic whole body manifestations of a severe infection, which is called sepsis? So what do you guys think? Go ahead and start putting in your answers. Let me know what you think. We got some infection right there, some sepsis. All right, some hypoglycemia. Yeah, definitely. Both of those can cause altered mental status, confusion. All right. Seeing a little bit of A, a little bit of D. Okay. All right. Very cool. Any other brave ones? Christian was thinking TIA, a transient ischemic attack. The preferred term now is transient neurological attack. Definitely see what you noted there with a normal neurological exam. So one of the main important things is that you never close your eyes and your ears because you might be surprised. Okay, all right. This is the CT, the computed tomography of the patient's brain. Anybody that's walking in with altered mental status, stroke-like symptoms, we get a CT of the brain. And you're going to notice right there, if you're looking on your left, which is going to be the patient's right. Okay. So you got to be looking at this like you're looking at the patient at the head of the bed, and their feet are closest to you and the head is farthest away from you. So that's a cross section of the brain. Okay. So you're going to see that that bottom part of the brain does not look like the other. You see that big black gap right there. What we know that is that patient has had a stroke, and that stroke wasn't new. Okay, it would have popped up a few days ago. That's a pretty significant stroke. Okay, and if you look on the right side, you can see right there on the EKG leads, you can see V1, V2, and V3, and you see those peaks pointing upward. Those are called the T waves. All right, T as in Tom. They're sloping upwards. They're very, very sharp. Okay, in this clinical setting, this signifies that the patient is also having an acute myocardial infarction, a heart attack. Okay, he is having actual ischemia, loss of blood flow to the coronary arteries around his heart. Ladies and gents, so what happened here is this was the first time that I saw something that I had only read about in patients with COVID 19. COVID 19 is particularly deadly for many reasons, but one of the ways in which it is deadly, it causes hypercoagulability. Patients clot at a much higher rate than normal patients. Okay. And as a result, they can develop clots in their brain, leading to strokes. They can develop clots in their coronary arteries, leading to heart attacks. And they can lead to deep venous thrombosis, etc., pulmonary embolisms. And so anybody who tries to minimize COVID-19 saying the survival rate is really high, well, this gentleman died the very next morning. Okay. He went to the ICU that evening, didn't do very well. And within 24 hours of my seeing him alive in the flesh, he was dead. For anybody who tries to minimize COVID-19, saying it's not a big deal, I would love for them to have the opportunity to jump in on a call when you have to call the patient's wife and let them know that her husband of 48 years died. Okay. If you have any friends or family members who want to minimize COVID 19, I fully invite them to come in one of these days and have a phone conversation with the family member of a deceased patient, and then we'll talk. Let's do our very best to understand that even though a lot of people survived this, many people like this gentleman died as a result, and it was totally preventable. Okay. And we as a physicians, as healthcare clinicians, owe it to our community to convey to the general public how significant this disease is. And I thank you once again for doing your part in making sure that this doesn't get any worse than it already is. Okay. So I'm going to dedicate this slide to that gentleman because I remember specifically his face, and I remember that conversation with his wife, and it's absolutely heartbreaking when you have to give those conversations. All right. Now, I am a clinician at heart in the emergency department, but my job as a professor within the university involves many cool aspects. All right. One of my favorite aspects of my job is the education of medical trainees. Right there on your left-hand side, you see me. This is on a Saturday. Talk about my day off. Talk about sacrifice. I am teaching advanced cardiac life support to a group of second-year medical students. These students are the cream of the crop. To get into UT Southwestern, they got to have the MCAT. They got to have the GPA. And because of the sacrifices they made and the amount of work that they put into getting where they are, they get the opportunity to learn life-saving skills one-on-one with me. And that is a privilege of a lifetime for me to be able to share my knowledge with them and impart that knowledge. Just like I was afforded the opportunity many years ago to learn about medicine and to be taught by phenomenal instructors, professors, and educators, now I'm giving back to the community. And this is one of my favorite things to do. I told you earlier that I did a fellowship in emergency medical services. Okay. So when you call 911 today for a medical emergency and paramedics or EMTs come out, they are going to give you medical care. To guide them on that medical care, to develop the clinical protocols and the guidelines, they need a medical director. Okay. So I am very fortunate to serve as the medical director for Hutchins Fire Department, which is a fire department here in the Dallas-Fort Worth area. And I am the one that helps them with the development of their medical care. Okay. One of the most fun things about my time with Hutchins Fire Department is that I also get to do firefighting with them. And that is one of our new fire suppression apparatuses, AKA a fire truck. And there is no bigger blast to me as a physician to be able to go and go fight some fires with my firefighter paramedics. Okay. If you want to learn how to do this, then follow in my footsteps, put in the work that it takes to get to medical school and beyond. And one day you could be a medical director for a fire department just like me. So I try to have a little bit of fun as well. And I love Hutchins Fire Department. They treat me like family, and it's a blast to do something that we don't do on a day-to-day basis in the hospital, which is to put out fires. Case number 2. This case is very similar to one of the first cases that I saw during the pandemic. Okay, this was a 31-year-old woman with no past medical history, pretty healthy. Okay, came into the emergency department for shortness of breath. She had fever for almost a week. And when you asked about risks, exposures to COVID-19, she tells you that she had been at spring break a couple of days before, attended a couple of parties, of course, with no social physical distancing, of course, no masks. And these are the vital signs when the patient came in. You know the blood pressure is low. You know the heart rate is very high. You know the patient is febrile. You know the respiratory is very elevated. It should be between 12 and 18, and it is 26. And most scary is that her oxygen saturation, which should be above 94%, is an abysmal 72%. Okay. And ladies and gents, this is what you see with COVID-19. When I see this, I can already begin to formulate in my head what I'm going to begin to see, the kind of treatment I'm going to have to provide. And one of the things that we do very early on in the patient's course is to get an x-ray of their chest to take a look. Okay. So a couple of things to note. The patient's right is on your left and the patient's left is on your right. Anything that is black within the thoracic cavity is air. Anything that is white is solid tissue or fluid. Right there in the middle, you see kind of a big silhouette that's smack in the middle. That's the patient's heart silhouette, which is normal. But you see there at the basis of the thorax, which should be black, okay, you see a lot of haziness, a lot of cloudiness, okay? That is classic COVID-19. So what's happening is COVID-19 creates a very bad inflammation in the patient's lungs, in their alveoli, in their airways. They fill with fluid. And guess what the symptoms are going to be? Shortness of breath, coughing, fever. You're going to note low oxygen saturation. Okay. This is a classic x-ray for COVID-19. So, all right, you clinicians. So what do you think we should do for this patient? What is going to be the first step in your management? Should we go ahead and put an endotracheal tube, which is to assist the patient's breathing, put a tube in their trachea? Should we administer some high flow oxygen through a little nasal cannula, a little hose in their nose? Should we start some antibiotics for the patient, maybe some fluids in there? Remember, they were very tachycardic. Could we possibly discharge them home on some antibiotics? Okay. Let's see what you guys think. I think the majority of you are taking a look at B is looking very tempted for you. Okay. All right. So what we're going to be doing, guys, is actually, we got to make a really tough decision right here. Okay. You got to remember the following. With COVID-19, one of the most difficult things is bed space, beds in a hospital. Okay. We have a limited capability. You can't build a hospital overnight. But even more concerning than that is you can't build physicians. You can't train nurses. You can't train physician assistants from one night to the next day. Okay. So you may have all the beds available in the world, but when you don't have clinicians to take care of these patients, that's a real problem. All right. One of the biggest things about COVID-19 is if you commit somebody to a ventilator, if you make the decision, this patient needs to be mechanically ventilated, we need to take over their breathing, we commit them to an ICU bed. That's an ICU bed that you don't have later on for another patient. So we have had to get very creative and use out of the box treatment. So one of the things we might consider in this patient, despite the low oxygen saturation, is use high flow oxygen, which is basically oxygen at a higher level. We humidify it so that it's not so tough on your airways, and we heat it up as well, and it's moisturized so that it's much easier to tolerate. Okay. And we're going to watch these folks and hope and pray, perhaps use some medications, hoping and praying that the patient is not going to get worse and wind up needing on a ventilator. We talk about, yeah, some people are going to get through it just fine. But ladies and gents, I have had personal friends of mine, personal friends of my family, personal friends and parents of some of my pre-healths who have died. And I can tell you this, once somebody goes on a ventilator, it's very tough. The road is tough. Don't take a chance. You may recover just fine. That's great. Don't take any chances. Okay. This patient wound up doing pretty well. The only problem is that we are noticing now something called long hauler syndrome, in which patients develop what's called COVID-associated pulmonary fibrosis, scarring of the lungs, and they walk around for weeks and months, and some of them even a lifetime of problems, including shortness of breath, fatigue, body aches, and psychiatric illness. Okay, so it's not just about recovery, it's about the long-term effects. Don't take the chance. Stay home, wear your mask. You don't want to wind up like this patient. When we are making decisions about how to manage a patient's breathing and their ventilation, we don't take these decisions lightly. Many things go into it. Okay. We talk about training all the time and how much schooling goes into it and the amount of preparation. Here's my second year resident, Chris Nelson. You got to remember, Chris is not a lot different than you. He's just a little bit older than you. Okay. He was a pre-med just like you, went to undergrad just like you, went to medical school like many of you hope to do today, got through medical school, and then matched at one of the top programs in emergency medicine in the world. Okay. Because of Chris's sacrifice, because of his diligence, because he is an elite student, an elite doctor, he gets to train at a world-class medical center. And here he is practicing one of the most important skills in an emergency medicine physician's arsenal, and that is an endotracheal intubation. Remember, I told you about putting an airway in the patient's trachea. Well, here he is practicing it. Okay. Notice a couple of things that he's doing with his left hand. He's got the laryngoscope, which helps you basically lift the tongue out of the way. On his right side, on his right hand, he's got the endotracheal tube with that little green tip. Okay. And notice that he's not looking at the patient's mouth. He's actually looking at a screen. So on the handle of the laryngoscope on his left hand, there is a fiber optic camera. And so Chris gets to see where he's going by looking at the patient's trachea and the vocal cords through the camera. Isn't that cool? You don't get to do that without proper training, without knowing your anatomy, without knowing the physiology, without knowing the procedural skills. It takes a lot to be a clinician, guys. So I show you these pictures and I tell you these stories to motivate you and keep you going, because the road is tough, the road is steep, and it's full with challenges. And if you rise to the occasion and you do what you have to do, then you can be in Chris's shoes one day. All right. Notice something very cool about this picture. One of the scariest things and saddest things about COVID-19 for an emergency physician like me was that very early on in the pandemic, we started learning about many of my colleagues in New York City and in Seattle getting sick from COVID-19, deathly ill, and some of them dying. Okay. One of the things that we learned as a result of their deaths, and we owe them a great deal, was that when you're intubating somebody, that is one of the most transmissible times of the patient's life where they can actually transmit COVID-19 to you. That's when you're exposed the most to their secretions. It's aerosols. So you can imagine the patient's mouth is open, you're instrumenting the trachea, you're allowing COVID virus all over your room, and guess where that goes? Right into your airways. So one of the things that was developed by a Taiwanese physician was this intubation box, which is that clear acrylic box through which Chris has his hands. And what that does, that greatly minimizes the amount of aerosols and secretions that come your way when you're intubating a patient with COVID-19. We owe a lot to many physicians who died, who recovered, who invented things, okay, to keep the rest of us safe. All right. Part of being a good clinician going forward is teaching others, sharing information with others. And that's been invaluable, completely invaluable in emergency medicine during this pandemic. So you all should strive to be like Chris Nelson one day. Not only is he a really good doc, he's a really good guy too. Okay. We talked about safety for us. When you are seeing patients with what you know is COVID-19, proven COVID-19, I can't say to the patient, sir, I'm not going to see you today. Ma'am, I'm not going to see you today. I don't want to expose myself. That's not what medicine is all about. I will put my life at risk to help that patient, to put my knowledge and my expertise to try to help him as best as I can. And so guess what I'm going to do? I'm going to put on my PPE and I'm going to go into that room fearless. All right. One of the ways in which we keep ourselves healthy is by doing frequent testing. So here is me going into the occupational health clinic where we have scheduled COVID-19 tests. And they put you in a room. You already have the swab, and you swab yourself so you don't expose the person getting the swab. So you learn how to do it yourself. It's not fun. It's not pleasant, but you do it with a smile on your face because you know that that is a way to keep you safe. I'm going to share something good with you. I've had no less than 6 tests. Okay, no less. You lose count after a while. Guess how many positive tests I've had so far? Take a wild guess. 0. Okay, Zippo. Deep V4. No, not at all. Let me tell you why it's at 0. When this started, my family and I, we promised ourselves that we were going to be diligent and conservative about this. Okay, which means we don't take chances. We don't go to restaurants. We don't have gatherings. I don't go to parties. I don't go to the store without my mask. And if somebody is going to come visit me, they're going to be wearing their mask. Okay. We have a tight bubble. I get to see my parents because they are taking care of themselves with the same degree of respect that I'm taking care of myself. And they know that if they get sick, they can get me sick. And I know that if I get sick, I can get them sick. That's the only way that we're allowed to see each other is by creating bubbles and by being diligent and not taking chances. So I've had 0 tests that are positive. Now, before the vaccination, I also had 0 antibodies against COVID-19, which is what you would expect. We've never been faced with this virus, never. So I would be negative for the test for acute disease, negative for antibodies, which is what we expect. Okay. On had my second dose of the Pfizer vaccine last month, and 3 days after my vaccine, well, guess what popped up positive? Beautiful IgG. Okay. I have a picture of it on my Instagram account. I'll put my account there at the end so you guys can go visit and check out some cool pictures. So now I have beautiful IgG coursing through my vein and acquiring it in the safest way possible, which is the vaccine. Okay. Ladies and gents, if we're going to get through this vaccine, through this pandemic, we got to get vaccinated. We cannot achieve herd immunity without the vaccine. It's never been done in our lifetimes. It won't happen now. There is really good data about that. Just ask our folks in Brazil. In some areas in Brazil, there's a 76% prevalence of COVID-19. 76% of people have had COVID-19 in some areas of Brazil. Do they have herd immunity? Nope, not at all. Get vaccinated as soon as you can. There is a lot of misinformation out there about vaccines. I'll tell you this, I have devoted a lifetime of looking at the science and the data to make really good decisions for my patients. And I'm going to treat my vaccination with the same degree of respect. And so I looked at the science, I looked at the data. And ladies and gents, well, I had a band-aid on my shoulder a couple of weeks ago. And because of that, I have beautiful IgG protecting me now. Get vaccinated. Okay. All right, we're rocking right along. We're going to go through our next case right here. We have a 45-year-old man with a history of high blood pressure. He comes in with 2 weeks of progressive loss of sleep. He can't fall asleep. When he finally falls asleep, can't stay asleep, turns on the TV and stays there until it's time to go to work. He has had bad anxiety attacks, superbly difficult to get his job done when you're that anxious. And at some points, he's thought about taking his own life. When you interview him, you find out that he lost his job as an insurance agent. He got furloughed due to the pandemic, and probably also because he was having some behavioral issues at work with his anxiety. Okay. On your physical exam, you note a flat affect in which the patient doesn't have really sadness or happiness in their face. Their expression is just flat. Okay. He becomes tearful at times. He makes poor eye contact with you. And this is something that I see since the pandemic started. Okay. This is not infrequent at all. So walk me through how we take care of this gentleman. And he may be, you yourself might be experiencing it. You yourself may know somebody who's been experiencing. So do you get a psychiatric evaluation on him? Do you call the psychiatrist? Do you initiate them on medications? Tell them take this, call me in the morning. Do you want to talk to the patient a little bit longer? Or do you let the patient go with some outpatient resources? Remember, there's no wrong answers. I just want to see kind of how you guys are feeling about this. Yeah, so there's a little bit of love for ordering psychiatric evaluation, interviewing the patients. Yep, absolutely. Yep, I like it. I like it. Okay, let's move on. Ladies and gents, um, COVID-19 has been very tough on the mental health for both healthcare workers and for patients at large. You can imagine the social isolation, the fear, the concern, the financial implications, the social implications, psychological implications. There are many things that have contributed to an elevated level of anxiety and an uptick in cases of patients with psychiatric disorders manifesting themselves even more during the pandemic. The case I just showed you is a real case, and I see it all too often. Did this happen because the patient is a bad person? No. He's a hard worker, just like you, just like me, just like your dad. Okay. Did this happen because he did not have proper coping mechanisms? Well, he's been functioning fine for many years, but how much can a person really take? Okay. Got mouths to feed. He's got a family. He's got kiddos. How can he go on socially? All right. So when we see these patients, the right answer, the first thing to do is you as a clinician have a responsibility of not just ordering stuff. One of your jobs as a clinician is going to be, remember the word service. This patient benefited way more from anything else that I did that day from sitting down with him for 5 minutes. 5 minutes. Okay. Talking a little bit about his family, his work, and how this pandemic affected him. Okay. Yes, I knew that he needed eventually to see a psychiatrist to establish and coordinate a treatment plan with him. I knew that he might need some medications eventually, though some behavioral therapy might help him as well. I knew that he might have been on his way to go home. All right. But the most important thing as a clinician, ladies and gents, is the skill of empathy. Empathy. Empathy means the ability to connect with somebody and understand and grasp what they're going through without having experienced it yourself. That is sympathy. They're different. I will not know what it's like to be an insurance agent. I may not know what it's like to lose a job, knock on wood. I may not know what it's like to not be able to pay the bills, but I know this. I know that he's a gentleman, much like me, with a family, with goals in his life and a lot of stressors. And the best thing that I could do in that moment in time is offer him a little encouragement, letting him know everything is going to be okay. I am busy and there are many more patients to see, but in that moment, he needed me and I was there for him. Remember that you're there to be of service. It's great that you're going to know everything there is about pharmacology for this patient and that you know how to order things on your computer and order psychiatry. That's phenomenal. But what's going to differentiate you from an average clinician, an average health professional is your ability to demonstrate and put into place the empathy that you need to take care of patients. I'm going to say this over and over and over again. If you learn nothing from me today, you are going to make a name for yourself and you're going to live in the halls of the house of medicine forever and ever because of your compassion and your empathy, not because how great you were ordering stuff or how great you were in the operating room. That stuff is minimal. That stuff doesn't matter. You'll be forgotten very soon. But I hope that I left an impression on that gentleman that day. And I know, as a matter of fact, that if I had been in his shoes and he had been in my shoes, he would have done the same for me. That's what you want in a clinician patient relationship. Don't forget that. All right. So we talked about mental health. I am big into mental health. That is one of my babies. You have to take care of your mental health. There is no ifs and buts. You have to do it. Okay. If you're going to last a long time and work at a high level and provide for your family, you got to take care of your mental health. There are many ways to do it. I'm going to share a little bit about how I do it during this pandemic. So there's a couple of things that are really important to me. First and foremost is my family. My family knows what I do for a living. They know the risk that I take every day. They know the risk that it entails living with me, but they accept it because they're my family. And family is the most important thing we have. They're the only thing that you have when everything else fails. They're the only thing that you have. And that's all I have. Okay. Cherish your family. Work hard for your family. Sacrifice for your family. Be kind with your family. They're everything to you. And sometimes we don't appreciate them enough until we need them. Until you ask your wife and your daughter to not go anywhere, even though they know it's a risk living with you based on your work. Okay. My family is remarkably important to me. I'm a homebody. I don't go out as it is. So this pandemic, to be quite frank with you, do I miss going to some restaurants? Yeah. But you know what? Being here at home with my family means a heck of a lot more than the social experiment of going out to a restaurant. Yeah, we'll get takeout. Yeah, we can get a lot of takeout, but being with my family is most important. Okay. Now, my one of my hobbies to keep my mental health, keep me stimulated outside of work is cooking. I love cooking. I'm not great at it, but every once in a while, I'll surprise you. All right. I surprise myself actually. So this is my Thanksgiving turkey. I'm very proud of this turkey because this was the best turkey that I've ever had in my life. And guys, I knew that the turkey was great when there was none left. And I mean zero left when I brought it to my family's table. Okay. I was able to bring in my family. And remember, we are only seeing each other in person because we're in a bubble, not for any other reason. Okay. And that turkey was gone. I brined it the night before, which means that you leave it in a kind of a salt bath to impart some liquid into it, make it moist. I prepared a garlic butter in it to kind of baste the skin and make it nice and crispy and garlicky and salty, delicious. And then I put it in my smoker so that it's now like got that smoky barbecue taste. I am making myself hungry thinking about how good this turkey was. Why do I like cooking? Well, it's fun cooking, but the thing that gives me the most joy, it's a process, and I like the most that people like what I make. I like seeing the joy in their faces. That brings value, that brings fulfillment to my life, knowing that they enjoyed the turkey. Okay. What else do I do for to take care of my physical and mental health? I am a devoted camp gladiator for 4 years. I work out 4 days a week, rain or shine. It's all outdoors. And my teammates and I go out on the pavement, cold, hot, it doesn't matter. And we're able to do it because we do it outside and we're socially distanced. And to this day, we've had zero infections of COVID-19 that we attribute to being in camp. Why? Because it's outdoors. Your risk of acquiring COVID-19 in the outdoors is very itty bitty. You take precautions too. Okay. What my workout does, it allows me to stay physically healthy. It gives me an outlet. It gives me something to look forward to. I love seeing my teammates. I love putting in the work. And I celebrated my 700th workouts the week before last on the 20th on Inauguration Day. Okay. 700 hours of hard work. And it doesn't matter how cold or how hot it is, you're going to find me on the pavements with my tennis shoes and my athletic wear. And I'll be very proud to announce I just became a physician athlete, a sponsored physician athlete by Circle Water. I would have never thought little Gil Salazar from Dallas, Texas would ever be a sponsored athlete. But through a stroke of luck and making some good friends and putting in the work physically and mentally, I am a sponsored athlete by Circle Water. Okay, so how cool is that? Never in my lifetime. Okay, it is only because of this balance that I have with my work that brings me fulfillment, with my life here at home and my mental health, that I'm able to do what I do in the long run. I don't know how much longer I'll be doing medicine, to be honest with you. Some days I think I may want to retire a little bit early and go do something different and fun and travel. Some days I think I might be like Dr. Fowler and be working into my late 60s. I don't know. By the way, if you've never been to virtual shadowing, have you guys been to virtual shadowing? You may have met Dr. Fowler before. So Dr. Fowler and I work together, and Dr. Fowler and I, it's not even friends, guys. This is like a father-son relationship. He treats me like his son. I treat him like he's kind of like my dad. And plus, the age difference is also kind of matching. But he is one of the reasons I love working where I am. I love my work family. Okay. When you love what you do, when the good outweighs the difficult parts, when you're able to take care of your mental and physical health, and when you love working with your colleagues, you're going to practice a long time. So I don't know how much longer I'll be working in medicine, but I can tell you that when it's all said and done, I'll be very satisfied with what I've done. Okay? Last piece of advice that I'm going to give you, and then I'm going to open it up to questions. As I mentioned before, I'm only here because a lot of folks along the way opened the doors for me, and they made sacrifices for me, and they gave of their time, of their money, of their effort, their mentorship, and their friendship to push me along. Otherwise, I wouldn't be here. So this is my way of paying it forward. The kindness that I received coming up is the kindness that I give you today, my way of honoring you. And all I ask you to do are two things. One, always remember that this is a career of service. If you go into medicine thinking it's for the money or the glory, for the accolades, you're not going to last very long and you're going to be burnt out. I promise you that. If you go into it to be of service, true service to patients, you'll be able to do this for a very long time, and you'll be remembered in the halls of medicine for a long time. Number two, pay it forward. The kindness that I'm giving you today, I don't do it for my accolades or because it's something that I feel I have to do. I do it because I know that this is my way of honoring those who have come before me. And I want to inspire you to do the same. When you're in my shoes, when I'm in a cabin and maybe in the snowy mountains of Colorado, retired, and you guys are leading these sessions, I want you to treat the next generation with the love and respect that they deserve. Okay? In a selfish way, I do this because your generation is going to be taking care of my generation when I'm done. And just like I treat my patients with kindness, with a spirit of service, hopefully, if you ever take care of me, I will expect the same from you. Okay? That's the only reason I do it. I run a pretty brisk um, Insta account. I post almost daily content, medical kind of knowledge, pictures. I give updates on our program. I expose you to my residents, to my nurses, my PAs, and it's my also my way of kind of giving you, opening up a window into the world of medicine for you. Okay. This is my QR code. All you have to do if you've never used it is put your camera to it. That'll lead you to our VCOP website. The Virtual Clinical Observation Program is a program that I put together. We had our very first session last night, and we open up registration and payment today. And the only reason we collect payment is because we use a learning management system where you can access the old recordings, you can print out certificates, you have access to the VCOP library as part of Career Cert. So it keeps the lights on. I don't get a dime from it. It's to keep the lights on. And additionally, we can actually give out a couple of scholarships here and there. Okay. So all the info that you need for VCOP is on my Insta, on the website. And then there's the link in my bio on my Instagram account is the link to registration and payment. Our next session is going to be the first Thursday in March. I can't remember what date that is, but it's the first Thursday in March at 7 p.m. Central Standard Time. So, okay, guys, it is 3:04 exactly, and I wanted to keep it to about an hour for you and leave a few minutes for questions. And so I would definitely welcome your questions at this point. You can put it in the chat or unmute yourselves, whatever Abby tells you to do. She's the boss.
Yeah, so I actually see a question from a few minutes ago. You can look at it
Yeah,
in the chat.
let's see what we got. Okay, are similar long-term effects seen with other SARS viruses other than COVID, or is it something specific to COVID? Thank you, Christian, for your question. SARS has been around for a very long time. It wasn't until SARS-CoV-2 that we started seeing this long hauler type of deal. Now, I can't tell you with a good degree of certainty if long hauler effects have been seen in societies where SARS hit them hard. Okay. For example, MERS that hit the Middle East, SARS like Asia, etc. I can't tell you if we've seen similar long hauler syndromes. I don't think so. What I can tell you is that SARS-CoV-2 associated pulmonary fibrosis is the real deal. It's absolutely devastating. And I have had many folks over the course of the last several months coming in on a not an infrequent basis to seek emergency care for long hauler syndrome because they can't breathe. They feel horrible. Their body is hurting. They have trouble. They have chest discomfort, bad headaches, constant nausea. It's scary what's out there. So thank you, Christian, for your question. I'm sure we're going to be learning a lot more about SARS-CoV-2 long hauler syndrome as time goes along. All right, guys, don't be shy. I won't bite you. Nobody there? Okay. All right. Well, I imparted my words of what I think is wisdom to you. I am very proud of the work that you guys have been doing. You guys, as I said, have been doing your work, contributing to the mission by adapting to a very challenging learning environment. And that makes me very proud. And why that is meaningful is because by you doing the right thing, that means that the resources are there for patients who do acquire COVID 19 and we can take care of them a lot easier. There are many struggling cities around the world, especially here in the United States. And we all have to do our part as Americans. I became a citizen of the United States right after 9/11 because of the unity and a sense of pride in our country, despite that horrible day. And I was hoping the same for this pandemic, and I was wrong. So do the right thing. As an international student, other than GPA, MCAT, volunteering, and clinical experience, what other factors can make one stand out? Thank you deeply for your note. Um, a lot of things go into your application for professional school, like medical school. Okay, um, there's a cookie cutter approach to it where you see a kid with good MCAT, decent GPA. They got like 36,000 volunteering hours and like 48,000 shadowing hours. But then when you ask them about one specific aspect of their volunteering or clinical experience, it's pretty shallow. You get bored when you interview them, to be very honest with you. So my best advice to you is you don't have to do 38,000 things for the sake of putting them on an application. That's poor use of your time. What I would rather you do, what I would rather see, the kind of physician student that I want working with me are folks who are legitimately humanistic. Some of the best applicants in my career have been those who have really shown by in different ways that they're true human beings who really grasp the concept of service. Okay. Yeah, you can volunteer all you want, but is that really service? Is spending 2 weeks in Tanzania really service, or is that just like a nice thing to put on your application? Guys, look for opportunities to be of true service. It doesn't even have to be medical. Some of the best applicants in my career were founders of centers. For example, Umer in Nitish, two of my second year medical students, they founded an emergency medical response group at their university that basically helps the fire department with 911 calls. They were the founders, and now it's one of the biggest college-based organizations in the world. They were really good students, but guys, when you look at these applicants, they didn't do like 88,000 hours of volunteering. They set up something meaningful, something humanistic. That's the kind of stuff that I want to see. All right, Christian, always appreciated comments of virtual shadowing. Glad to have this opportunity. One more question. A person born in another country, do you find a drive toward humanitarian aid in other countries? Christian, that's a phenomenal question. Um, what I'm about to tell you is going to sound a little bit tough. Okay. Um, I think that volunteering abroad, especially when you're a pre-health, is kind of marginalizes some groups that can't afford those opportunities. When I was coming up as a pre-med, my parents didn't have the money to send me to Tanzania for 2 weeks. Um, and yeah, I was bummed out because some of my classmates were going to exotic places and spending 2 weeks and sending pictures. And I was like, well, what about me? Only to find out, guys, that the work that I did, for example, volunteering at Parkland Hospital, drawing blood and being an interpreter was far more meaningful to my growth as a clinician than, say, a 2 week experience in Rwanda. Do I think that's a valuable experience? Yeah, probably. But guys, like if it really brings humanistic value and service value to you, do it by all means. But humanitarian work, um, there's so much to do in our country right now. So many kids, so many older folks, so many folks with disabilities who could use our help right now. So my advice to you, it sounds a little bit rough. Let's focus on our communities. Let's focus on the communities here at home. And if someday you're called to be of service to other countries, yeah, absolutely do it. But let's start very basic. Don't take strides that are way too long, or you're gonna find yourself kind of lost. So start at your community level, Christian, and then later on in life, if you have that calling, you have the resources and the finances to do it, and it brings value to you because you really want to do it, then do it. Walt Green is one of my colleagues here at UT Southwestern, and he goes to Central America every year. Does he do it because he needs to get into med school? No. Why does he do it? A while back, when he had that experience, he learned that it brings value to his life of service. So he serves his community here now in Texas, and then goes once a year to Guatemala to serve my fellow countrymen. But he does it because he really likes it, and it brings service, and it's of value to him, not for any other reason. Well, all right, guys, it is 3:15. I am so very glad. I'm going to do another lecture here shortly. So I am so delighted to be here. Um, get me a follow on Insta. We hope to see you on VCOP. We look forward to seeing all of you guys. I really want to make sure that I inspired you in some way today, and that you learned a little bit of something. Okay, I'm very proud of you. Keep up the great work, and if we can be of service, let us know. Okay.
Thank you so much. I just had one last question.
Sure.
So you mentioned earlier how important your family is to you, and I was just wondering because of like stuff I heard on the internet and from like other doctors that being an emergency room physician is a lot like time commitment, and some doctors feel like they don't have enough time for their families. Do you think that's the case?
I work more hours than your average person. I really do. And part of being a physician, remember sacrifice and service. Yeah. Part of being a clinician is that you're going to work a lot. And so the way I will answer your question, Michelle, is by telling you that you're going to go through some periods in your life where you're overcommitted. Okay. And where you're going to put your family in bad positions sometimes, where you have to miss your kid's birthday party, or miss dinner with your wife. Um, and the only way to mitigate that is by having a family who really understands and supports you no matter what, when you're not doing your best. Um, and so, yes, we're very busy, but I only get to keep my family because my family is that special to me. They're so generous to me with their understanding, and they know that some nights I have to go to work and I can't help with homework, for example. Yes, it's a sacrifice. That's a sacrifice you make as a clinician.
Okay, thank you. So I just want to end off by saying thank you so much for coming. I also had a quick question, not related to like medicine, but
Sure.
you mentioned earlier that you would like the cases that you presented today to not be shared. But is it okay if we post this video on our YouTube page, or would you like us to take that part out?
Let's see. Allow me to do the following, because I'm going to be doing the same presentation for a couple of other groups in the next 2 weeks. So do me a favor. Let's set a deadline. You can start posting it after, what is February 5th right now? How about give me 3 weeks?
Okay.
That be okay?
Yeah, that sounds great. Okay. Thank you so much for coming. I learned a lot, and I could really see your passion for medicine, and it's very inspiring. So thank you so much.
You're so welcome, guys. You'll have a great weekend. Stay safe. Keep hitting the books, and most importantly, let's be of service to our communities. All right.
Thank you.